Good morning, everyone, and welcome to this morning's case study. My name is Anastasia, and I'm a clinician educator at Genova Diagnostics, and we are delighted to be hosting Joe Gamble for an interesting case study looking at the presentation of rheumatoid arthritis on the Metabolomix Plus and the GI effects. As I'm sure many of you know, Joe Gamble is a registered nutritional therapist as well as a certified functional medicine practitioner. And she also has a fellowship in integrative oncology with the American Board of Anti-Aging Health Practitioners. As always, there will be a chance to ask questions at the end of the presentation, so please do write your questions in the Q&A box in the GoToWebinar control panel as we go along the presentation. And I will be monitoring that box, and as well as that, I will also be relaying the questions to Joe at the very end. You'll also notice that there are some PDFs in the handout box as well in the control panel with the support guide of the tests in question, as well as the slides that Joe will be going through today. So without further ado, Joe, I'll let you take it away.
Brilliant, thank you, and thank you to everybody. So I like to really use case studies to display the information that we are able to get as clinicians from digging down deep. Many of you will have heard me lecture before and using clinical application, because that's what I do first and foremost. Is I'm a clinician, and what I love in my toolkit as a clinician is to be able to dig down deep and get data. So I didn't earn the title Queen of Testing easily. I use testing in probably 90% of my client base, and the only ones that I don't are honestly those that I can't, maybe because they're on active chemotherapy, they're pregnant. But for the majority of my clients, using testing is such an important tool in my toolkit to make a difference. So today I'm going to be looking at clinical application of autoimmunity, particularly of rheumatoid arthritis. But before I dig into the case, I thought I would sort of do a little bit of a dive into some of the research and the theories behind the human gut microbiome and autoimmunity. So we know that so much research has been undertaken about looking at the triggering factors of autoimmunity. And how often do you not think about the gut with that autoimmune client, whether it's a client with RA, like today's case study, whether it's a client with MS, psoriasis, Crohn's, colitis, celiac disease, the list goes on and on and on. But underpinning all of those is the gut and the gut microbiome. Why? Because we know that that gut microbiota, it regulates homeostasis of the immune system via the induction and development of the gastrointestinal immune regulatory system. So on one hand, the mucosal immune system regulates the structure and the function of the gut microbiota, and this bidirectional interaction is finely tuned under healthy conditions. So by not bombarding the immune system with the insults of today's living antibiotics, herbicides, pesticides, other pharmaceutical medication, non-steroidal, steroidals, oral contraceptive pill, thinking about bombarding it with stress, thinking about bombarding it with toxicants, what's in our makeup, our shampoos, our conditioners, our nail varnishes. The list of toxicants is absolutely colossal that we're coming into contact with. So we think about those regulatory T cells. There are subproportion of T cells that modulate the immune system, maintaining tolerance to self-antigens. And you may have come across this concept of loss of oral tolerance. It's something that's definitely talked about a lot in the complex autoimmune world, where somebody's lost tolerance to foods, lost tolerance to chemicals. And it's because their regulatory T cells are no longer working in harmony. And these cells generally suppress or downregulate the induction and proliferation of the effector T cells. Now, studies have demonstrated that bacteria like Clostridium is a strong inducer of T regulatory cells. How many of you have done organic acids tests and seen Clostridium come up and gone, well, they haven't got an acute infection, they're not acutely unwell, but maybe it's a chronic infection. Now, the gut microbiota plays a crucial role in the induction of those effector T cells in the gastrointestinal tract. Th17 are a novel class of helper CD4 T cells characterized by the secretion of interleukin 17 alpha, interleukin 21, interleukin 22, which are all involved in pro-inflammatory mediators. So we as clinicians need to bear this in mind. We can't just be working at the surface level. We need to be with complex autoimmunity working much deeper down and thinking about what has gone out of balance in that gut microbiome, in that immune regulatory system. So there are up to 100 trillion bacteria living in our guts. And the immune system walks a very fine balance between self and non-self. Does it regulate which bacteria belong to us? Or does it, in fact, as is the case in autoimmunity, see itself in the mirror and see non-self and therefore go in for the attack? That attack would not be happening if the microbiome was working in harmony. So we need to be thinking about that interface, that gut interface with the outside world. What are the system in your body comes into contact with everything that goes through the body? Nothing. The liver, the immune system directly, the kidneys. It's the gut that is the direct interface between what we put into our mouth, and I'm not just talking about food, I'm talking about herbicides and pesticides. I'm talking about fungicides. I'm thinking about what's grown on our food that not necessarily we want to, mold species that we're coming into contact with. And it's those contacts that really send the immune system out of balance. So the gut barrier gets compromised. Our ability to digest and harvest nutrients gets compromised. Our immune system gets compromised, and our defense and tolerance, hence the lack of self-tolerance, gets compromised. This is not harmony. This is the beginning of disease, and this can happen for many years before the symptoms of the disease start, which is why in the likes of anti-nuclear antibody status, an individual can be ANA positive for up to 10 years before they show the symptoms of the autoimmune disease. Now, ANA is not a classic blood marker ran by GPs, particularly in this country. But if it was regularly touched base with, we would potentially be able to reverse an autoimmune disease before it starts. So could I maybe suggest you did a stool test on an individual, they haven't got autoimmunity, you see a big alteration in the diversity of the commensal bacteria, and your brain goes, should I be running an ANA on this person, because these are a likely candidate for autoimmunity in the future. And maybe at that point their commensals are out of balance, they're ANA positive, all they need is a stressful life event, and boom, the autoimmune disease turns on. So this is how we can consider reversing autoimmunity. Now, if we think about the immune system, the dendritic cells can either bind to the toll-like receptors and activate kappa B, or engulf it by phagocytosis and present to the naive T cells. Then it sends signals, and we don't even really completely understand what that signaling is at this stage. And those co-stimulatory molecules tell the naive T cells, we're under attack, we're under bombardment, and that in turn turns the cell into a Th1 or a Th2 cell. So we know from immune system research that Th1 subsets of cytokines are more involved with cell-mediated immunity and delayed hypersensitivity response, which goes after viruses or certain intracellular bacteria. So autoimmune disease is associated with Th1 dominance, type 1 diabetes, multiple sclerosis, Hashimoto's, Graves, Crohn's, psoriasis, Sjogren's syndrome, celiac disease, rheumatoid arthritis, as well as chronic viral infections. Now, the Th2 subset are more involved with antibody responses, humoral immunity, and allergic responses. And they stimulate self-growth and differentiation and recruitment of mast cells. How many of you working with mast cell activation syndrome? Basophils, eosinophils, and B cells. Now, we know an individual is born more Th2 dominant, and when they come into the world, we should regulate their immune system as a nice, healthy seesaw between Th1 and Th2, which is why when you see babies with atopy, asthma, baby eczema, allergies, we know that they haven't made that change. But we're also seeing late onset Th2 regulation. Thinking about lupus, allergic dermatitis, scleroderma, atopic eczema, inflammatory bowel disease, asthma, allergies. Certain cancers are associated with Th2 dominance, ulcerative colitis, multiple chemical sensitivity. The person that goes into the lift with somebody wearing a strong perfume and they come out with a headache or feeling nauseous, that is your first insight into there is an immune system imbalance going on at this point. So when we think about the difference between a healthy immune system, many studies have uncovered alterations in the Treg compartment in autoimmunity. In mice, experimental manipulation of Tregs have profound effects on the incidence, onset, and severity of autoimmune diseases. Reducing the number or function of Tregs results in exacerbation of the disease, whereas replenishing defensive Treg populations in bacterial balance within the mouse of the within the gut of the mouse actually shows reduction in autoimmune diseases, which is why when we look at treatment of autoimmunity in the medical model of treatment, which is anti-inflammatories, disease-modifying drugs, biological therapies, or even newer categories like B-cell treatments, these are all, they're not looking at the root cause, and that's why we as practitioners have the upper hand, because we've got the ability to dig down deep into those root causes. So yes, we know that there can be genetic predispositions, HLA-DQ2, DQ8, which is a driver of celiac disease, type 1 diabetes, Hashimoto's. We even know that things like FT2 polymorphisms, which can give a less diverse microbiome, could put you at heightened risk of all autoimmune diseases. So thinking about that genomic instability can be key. Definitely thinking about infections, bacteria, viruses, molds. Thinking about toxic insult. What are people coming into contact with? Thinking about dietary components. Thinking about methylation factors, how well somebody can absorb their key nutrients, zinc, vitamin C for immune regulation. That is all part of our dig down deep and find out what's going on. So the balance of immunity is a combination of host genetic factors, exposure to environmental triggers, which promote the development of autoimmune diseases. A balance must be maintained between the regulatory T cells and the pathogenic T effector cells. So the reason I felt the need to sort of start at the beginning is to go, we need to be digging into all of this. Our job is not just to put fish oil in to work at the PPAR receptors. Our job is not just to put SCRMs in there, selective kinase reducing modulators. Our job is to find why, and only when you find why, you're really going to make a difference to autoimmunity. So thinking about those environmental insults, and I'm not just talking about what's happening now, I'm talking about the 5, 10, 20 years preceding diagnosis. Thinking about molecular mimicry, which is the most common mechanism that activates autoreactive T cells and B cells. Epitope spreading is a mechanism that results in generation of multiple neoepitopes. In addition, by modulating innate and adaptive immunity, the microbiota and nutrition, so things like vitamin D, iodine status, gluten loading, may also contribute to a loss of tolerance. Low vitamin D levels will encourage loss of tolerance, and therefore there will be more attack on self. So this is an overview and a really good just visual for you to keep. Mechanisms of autoimmunity for you to be thinking about. Those dietary insults, gluten and dairy are going to be top of the list. Thinking about medications, not just present, but historically. A historical exposure to corticosteroids is an almost given cause of leaky gut. Thinking about bacterial, yeast, viral, and parasitic infections. Thinking about stress insults, thinking about other hormonal imbalance, low thyroid, low progesterone, estrogen and testosterone levels, thinking about neurological brain trauma, injuries to the brain, obviously bigger injuries like stroke as well, and then thinking about metabolic processes, glycosylated end products, intestinal inflammation, all as drivers of autoimmunity. Now, of course, today I'm putting a big focus on the gut and gut autoimmunity. So we know that autoimmunity can be induced by infectious agents through various mechanisms: molecular mimicry, epitope spreading, standard activation, viral persistence, polyclonal activation, dysregulation of immune homeostasis, and auto-inflammatory activation of innate immunity. In some cases, even if infections are not directly responsible for the induction of autoimmunity, they can be a perpetuator, keep the fire burning, and often target the site of autoimmune inflammation and amplify the autoimmune disease. So this has been proven. I think it's Professor Christopher Bump, who is an American professor who has dedicated his life's work to looking at the impact of Epstein-Barr virus on multiple sclerosis. So he's not saying EBV was the absolute trigger. He's saying EBV is the perpetuator of the fire in many cases of multiple sclerosis. And that was actually reported on in BBC News in the last couple of years, saying Epstein-Barr virus can drive autoimmunity. It actually made it into conventional news, but yet it's been talked about in our profession. This guy has been dedicated in his life's work probably for 4 decades towards this. So we've known about it far longer than conventional medicine. Now, molecular mimicry is the most likely mechanism by which infection induces autoimmunity. Foreign antigens very often may bear sufficient structural similarities to self. And that's why when we look in the mirror, we don't see me, we see burglar. So of course, we're going to go in for attack where burglar is concerned. Mechanisms of infection-induced autoimmunity through molecular mimicry is what you can see in this picture on your slides. Given the vast numbers of microbial proteins and their cross-reaction with human proteins, immune response against microbial antigens will not always result in autoimmunity. However, such an initial immune response could result in the epitope spreading or exposure of other regions of the self-protein and produce more antibodies. So that is what we are considering in this phenomena. And then epitope spreading is a phenomena in which the immune system expands its response beyond the original epitope, the original exposure, recognized by our T cells or our B cells, to induce the release of non-cross-reactive epitopes that are recognized by the immune system later. Epitope spreading can result from a change in protein structure. So the newer classification of autoimmunity drugs like baricitinib, I think I'll put an extra R in there, baricitinib, which is a B cell squasher, is just wiping out the B cells, which, by the way, B cells regulate for cancer. So we know that being on that drug puts you at higher incidence of cancer. But what they're not looking at is why your B cells are activated, and that's what we're thinking of in this situation. So persistent infections will be the driving force of the increase in T cells and the increase in B cells. So if we think about the gut microbiota, which we know is the interface with the world, the outside world, the food, the drugs, the herbicides, the pesticides, is it any surprise that we are seeing huge amounts of pro-inflammatory mediators in these circumstances? Of course not. So what I want to now do is use that sort of science-based approach to apply it to a case study. So when I was asked to do today's lecture, I was sort of inundated with who could I use. But I felt that this case was actually a really good one to bring to life, because you know what? It actually was a really simple case to work on. And that's what I wanted, was to see the simplicity of using functional medicine and functional testing in clinical practice. So Hannah is a 33-year-old female who presented to me after a 12-month history of joint pain. She had a stressful lockdown, felt isolated, and was expected to work more as some of her team had been furloughed. So she was doing the work of 2 or even 3 people. She'd had COVID, which was PCR positive, and she felt all of her joints went achy, which is not an uncommon thing when you've got pro-inflammatory mediators associated with COVID. But then she didn't feel as though she recovered. So she presented to a GP at week 8 after COVID. He did some straightforward blood. CRP was 27, ESR was 40, ANA was positive, rheumatoid factor negative. Her white blood cells were raised at 9.3. So she was referred to rheumatology. She was treated with sulfasalazine, which caused diarrhea almost immediately, and then was treated with oral prednisolone for 6 weeks, and then started on weekly methotrexate injections. Her fatigue intensified. She felt nauseous for at least 3 days after each injection. Her mood dropped, and yet her joints were still getting worse and worse and worse. So she was getting all of the side effects and yet little of the benefits. So as always, I start off by plotting a timeline to see if that shows me any information. So starting off today, or the day she presented, joint pain and stiffness, gut symptoms, heavy painful periods, low mood. So let's go right back to the beginning. She's got a family history of autoimmunity. Her dad had got psoriasis, and her dad's sister, so her aunt, multiple sclerosis. Now, as a wee small baby, she was born early at 35 weeks by C-section because her mum had preeclampsia. So that whole exposure of the gut microbiome in vitro was diminished. She didn't get the lovely journey down the vaginal canal. Her mum then suffered with postnatal depression afterwards. So we know the research shows mum's hormones can influence baby's hormones. She hadn't been breastfed because she couldn't latch on because she was only 35 weeks. She didn't have a good suckle reflex. So therefore, early damage to the microbiome within that first 1,000 days, which I'll talk a little bit more about in a minute. Then she had frequent infections, tonsils, treated with antibiotics. She said her memory of banana medicine was strong. She was diagnosed with asthma at the age of 8, initially just treated with Ventolin, but then went on to also be treated with a steroid inhaler. She'd been bullied at school. She'd gone on the oral contraceptive pill at 15 for heavy, painful periods. She carried on getting recurrent infections. She'd had breast implants in 2018. She'd had her appendix removed, prior to that, the age of 23. Low mood at 25. She'd been prescribed antidepressants for 6 months, but didn't feel they worked. And then in COVID, she'd felt isolated. She had a relationship breakdown. She'd had post-antibiotics post-COVID antibiotics for a post-COVID chest infection, and then the beginning of long COVID symptoms after COVID with the tiredness that she was presenting with. So always do a review of systems. So from a gastrointestinal point of view, loose stools for 8 months. Started when I'd been on sulfasalazine, but not yet improved, even though she'd come off the sulfasalazine. Reactive gut after most foods. Hemorrhoids confirmed by the GP because she'd had some fresh red blood on the toilet paper. History of multiple antibiotics, prednisolone, non-steroidal anti-inflammatories, all managing her joints, obviously antibiotics for the recurrent infections. And she'd also been on PPIs, omeprazole for 8 months whilst on high-dose NSAIDs and prednisolone. From an endocrine point of view, high stress since March 2020. She said prior to that, she wasn't a stressed individual. She loved life. She loved socializing, but from COVID, it really got her tough. Lots of stress due to financial commitments. She was now feeling the pressure of needing to work. She'd had lots of time off and she'd gone through the flagging system, been referred to Occy Health, and she knew that she couldn't keep having time off. She'd been on the OCP from 15 to 26, and although her periods had initially settled into a 28-day cycle, they were now more like a 26-day cycle, and since COVID, they'd been incredibly heavy and clotty. Respiratory-wise, asthma since 8, now on Becotide as a preventer and Ventolin as needed. Since COVID, she'd been using her Ventolin much more for lung irritation, so definitely some respiratory stress going on. She had actually got some psoriasis on her scalp, not diagnosed, but when she ran her fingernail right next to her scalp, she was plaquing off skin. So that's very different to kind of classic dandruff. That sounds like scalp psoriasis. Her nervous system, some anxiety, which was worse premenstrually. She'd been on citalopram, but she took herself off it. Musculoskeletal system, the obvious rheumatoid arthritis, which was affecting her feet, her ankles, her knees, her fingers, and her wrists. She'd also had a back injury from falling off a horse at the age of 13 and bruising her coccyx, which whilst the bruising improved, she had always had a bit of a weakness, she said, to her back. It was worse when sitting, and her job was very sitting based. And she said she used to manage it by going out for a walk at lunchtime, but now she's neither got the energy nor managing her pain to be able to go out for a walk at lunchtime. From a detoxification point of view, lots of pain meds, paracetamol, non-steroidals, alcohol. She used to be a big binger. Cardiovascularly, nothing to report, no family history. So to look at her diet. Prior to COVID, she had a very much typical Western diet. She tended to eat takeaways once to twice a week. Her alcohol was 15 to 25 units a week, which usually came in the form of a couple of binges. So she wasn't a regular drinker. Didn't be the person that opened up a glass of wine in front of the TV at night. When she went out, she binged, which is very common. Since COVID, reactive to everything. She tried 3 weeks off gluten, but it didn't work, so she put it back in. More ready meals, because even simple things like peeling and chopping vegetables really was a difficulty because of the wrist stiffness, and the finger manipulation had reduced. She was now increasing her coffee up to 4 to 5 a day because her energy was so low. It was the only way she was getting through her work day. But she had reduced alcohol because the doctor had advised it since starting methotrexate. So from a lifestyle review point of view, pre-COVID, she described herself as a party animal, and that's what she did for socialization. Since COVID, a social reduce. Her friends were back to going out. She was very limited in that. She feels she hasn't got the energy to go out, even if it didn't revolve around alcohol. So she typically watches Netflix until 10 to 11 at night, and then she goes to bed with her phone and scrolls through Facebook or Instagram until she falls asleep. She used to sleep through the night, but now when she rolls over, comes out of a deep sleep, she's in pain, she's stiff, it brings her out, and then she struggles to get back to sleep again. She doesn't have any hobbies because it used to be socialization. So if we think about antecedents, triggers and mediators for her, so family history of autoimmunity with a dad and the dad's sister. She was premature and poor diversity in that first 1,000 days of life. So we know that that first 1,000 days, which is from egg meets sperm to about the child's second birthday, is absolutely pivotal to lay down that really lovely commensal bacteria. So what typically happens in that first 1,000 days of any child is mass vaccination, and with that all of the stabilizing agents. So you've got the insult of all of the viruses plus all the stabilizing agents, things like aluminium, formaldehyde, that's in the vaccination. Obviously it's not our job to advise people not to vaccinate, it's our job just to think about it. Generally when babies are vaccinated, they're then told, parents are told to give them Calpol. Now, Calpol isn't just about the insult of paracetamol, it's all of the flavor enhancers that go in it. Has anybody ever picked up a bottle of Calpol and looked at the side of it? So babies are told to have Calpol prophylactically to prevent a fever around vaccination. So when you go multiple infections, you probably go multiple exposure to Calpol. And once parents are used to giving Calpol, they typically give it for lots of things, teething, baby's a bit run down, etc., etc. Then what else happens during that time? Well, babies are generally exposed to gluten and dairy from a very young age. She was bottle fed on cow's milk formula. The advice, certainly in her age, was first baby food rice. So you're thinking about what's the exposure to heavy metals, what's the glycophosphates that are sprayed onto grains. All of this within that first 1,000 days. And then you name me many babies, especially when their immune system has been hit that hard with I don't know how many different vaccines, or they're not on antibiotics in that first 2 years. It's less common. Okay, granted, doctors now, rather than in her generation, are not so quick to give out antibiotics. But when the immune system starts to go out of balance, kids get more sick. Kids therefore end up with infections that require antibiotics. Babies being given baby Nurofen, non-steroidal anti-inflammatories, damage to the mucosal membranes. So I don't see many individuals, whether they're a child or an adult, that you go, that first 1,000 days wasn't an insult anyway. But this poor woman, she was born prematurely, so she wasn't in vitro long enough to be exposed to all that, the species of bacteria. We now know that good bacteria passes through the placenta, particularly in the third trimester. Third trimester was cut short by 5 weeks. She was born at 35 weeks. We know she wasn't born vaginally, so she wasn't exposed to those species of bacteria that should populate the vaginal canal. And at 35 weeks, skaboo, what was the first thing that touched her? Latex gloves, plastic incubators, which are cleaned with chemicals, not skin-to-skin contact with mummy. So that golden hour, as it's referred to, where they're meant to lie on mummy's chest and get the rooting reflex, just wouldn't happen when a baby goes straight to skaboo. Obviously, you wouldn't not want your baby in skaboo if they couldn't breathe properly, but I just want you to be thinking about that. So the beginning of her life, and then mum's depression, I think all really, really key to sabotaging the beginning of her immune regulation. So then is it any surprise she gets tonsillitis after tonsillitis after tonsillitis, more antibiotics going in, more damage to that commensal bacteria. So childhood, bullied, adverse childhood events are a known driving factor of autoimmunity. She's female. We see a ratio of 4 to 1 women with autoimmunity. Why? Because of the influence of estrogen, and she was on the OCP, a trigger. So when you start in your head to stack up these, no wonder she got autoimmunity. So the odds were stacked up years before the insult. That insult, yes, was the viral load of COVID. That insult could have been the breast implants, and I'll show you some research in a second. That insult was definitely stress, social isolation, but don't just think about that insult, think about the triggering events that went on before that. And that's what we're thinking about with the antecedents. The typical Western diet, high exposure to ready meals, takeaway foods, flavor enhancers. Again, we're loading her. Alcohol. I didn't actually put alcohol on there as a trigger. It should have been on there as a trigger. And then the mediators, the absolute perpetuators, COVID, the viral load of COVID, stress, antibiotics, and potentially those breast implants. Here's just a couple of research papers for you to look at autoimmune disease and breast implants. So we know that breast implants, silicone implants, can be a driving factor of autoimmunity. It's very well documented. So I'm not saying it was, but I also can't rule out it wasn't a triggering, perpetuating factor. And then we know the research has already started and will continue to happen, that COVID-19 is a driver of autoimmunity. This woman isn't even vaccinated because she was so sick, she was so frightened of them being vaccinated. So we know that the vaccine can be a driver of autoimmunity. I haven't even gone there where that's concerned because she wasn't vaccinated. It was the absolute virus that was her triggering factor. And here's the research for you on that first 1,000 days of life, on shaping the microbiota for the rest of our life. So I just wanted to drop in there, everything I'm thinking about is research-based, everything is backed up with science. So what did I do? Gluten and dairy free. I'm thinking about molecular mimicry. I'm thinking about attack on cell. I'm thinking about her seeing those gluten and casein peptides and mimicking her and going in for the attack. I know she'd done 3 weeks gluten-free, but I mean, come off it, what's 3 weeks? To increase her antioxidants, when there's that much inflammation, look at how high her CRP was, there's going to be oxidation. Fact. Inflammation triggers oxidation. Stress triggers inflammation that triggers oxidation. Fact. So I didn't want to go massively supplement orientated because I wanted to see whether or not she was digesting, whether she was absorbing. And now what I want to think about is raising up her fish oil, getting 3 grams in there, work on the PPAR receptors, and let's get some testing done. So I sent her off for a GI-FX, a Metabolomix, and repeat with a GP, which she was needing to do. They weren't doing her ESR regularly, but they were doing a CRP as part of her methotrexate bloods, but also vitamin D. So her stool test came back. So if we look at the 5 pillars on page 1, they don't actually scream. This wasn't the result that made me go, wow. She's got raised secretory IgA, giving her a 6 on her inflammation, but it doesn't make me go, wow. But I mean, I only look at those pillars with a bit of a pinch of salt. I dig into the data. So we can see her pancreatic elastase is low. A woman of her age, that should be definitely more than 500. So you're thinking slightly reduced absorption, and her products of protein breakdown is also low, thinking absorption in the small intestine is compromised. Now, this fecal secretory IgA, that straight away suggests the immune system is hyper-reactive. Is it hyper-reactive because of barrier breakdown and food reactivity? Is it hyperreactive because of viral load? Is it hyperreactive because of loss of oral tolerance to chemicals? You don't know, you just know it's hyperreactive. Butyrate is a bit on the low side. Short chain fatty acids is okay, so we're thinking commensal bacteria might not be optimal. It's not horrendous. We've got this raised isoflavonoid piga. Does that make us think there could be a potential SIBO going on in there? But her methanobravibacter is good, so more likely to be a hydrogen positive SIBO. Actually, shockingly, you would expect, I would have expected to see really low Akkermansia, which I didn't see. So commensally, not brilliant, not bad, but her lactobacillus is good. Her bifido is good. I was shocked to see that. Now, if we go on and look at the cultures, she's got Enterococcus faecalis. Now, Enterococcus faecalis is non-pathogenic in the gut, but it isn't non-pathogenic in other places in the body. Enterococcus faecalis, I was only lecturing yesterday on brain neuroinflammation. I made massive reference to Enterococcus faecalis. This is one of the bacteria that's associated with Alzheimer's disease. So please, if you see Enterococcus faecalis on the stool test and you're thinking barrier breakdown, I didn't actually add zonulin into hers, but I mean, I was thinking barrier breakdown. Then you've got to think about that could migrate outside of the gut, endotoxemia, not just permeable gut breakdown, gut barrier, permeable blood-brain barrier. She's got an aunt with MS. You've got to be thinking about all of those steps. Now, from a Metabolomix point of view, you can see in the pillars at the beginning, she's come across as like 5 to 7. So nothing's brilliant, nothing's horrendous, nothing brilliant. When we look at her antioxidant burden, I mean, truthfully, her diet was pretty shockingly low in antioxidants, but her need is also great because of the inflammation and oxidation. Her B vitamins are also pretty low. 2's good, but 1 and 3, both vital for mitochondrial function, are pretty low. And then all of those methylation factors. I always think poor methylation, I always think MTHFR, guilty until proven innocent, not innocent until proven guilty. And then her magnesium is high need for supplementation. Is it any surprise with the amount of stress that she's under? Of course not. Now, her amino acids are actually pretty good. I don't scream and shout at any till they hit 1,000, so I'm not worried about them. But when you look at her Krebs cycle, her lactic acid is raised. That's not good. I've got a cancer brain on me. I always see high lactic acid as an alarm bell for terrain. I don't like raised levels of lactic acid. And also she's got raised levels of suberik acid. So you're thinking, as I describe it to a client, petrol into the car is compromised. And then down here, let's look at the miles per gallon. It's not bad, but it's not ideal. So no wonder her energy is compromised. But simple things like the deficiencies in magnesium, B1, B3, glutathione, B3, magnesium, like she's deficient in all of these cofactors. You know, we're seeing some bacterial dysbiosis, but we've got that raised deucroflavonoidopyga, so that sort of adds weight to, yeah, probably a SIBO presentation. And then she's also got a bit of raised toxicity. Her oxidative stress markers actually aren't as bad as I would expect them to be, but there is oxidation. So she came back to see me after 4 weeks. She had most recent rheumatology review. So this, I haven't put anything in place other than the fish oil. CRP 20, ESR 23, vitamin D16. It had never been tested. They don't test it as standard. Her ferritin was 8. Again, no wonder she felt diabolical. White blood cells were still raised at 9.7. That makes me go, activation of her immune system. Current drugs, methotrexate, folic acid, because methotrexate is a folic acid antagonist, ibuprofen, and she was offered adalimumab, which is also known as Humira, so offered to go on to biologics. She'd been gluten and dairy free for 3 weeks and felt some improvement to her gut, not to her joints, but to her gut. And she'd been on the fish oil for 4 weeks. So plan number 2, to implement a 4R protocol using berberine and oregano because they work really nicely on SIBO. I didn't do a breath test. I didn't want to hold out any more time to prove my hypothesis right or wrong. She's got that bacterial dysbiosis on the Metabolomix. She's got that deucroflavonoidopyga on the GI-effects. It's like there's bacteria in there. And then put her on a broad spectrum digestive enzyme with lipase to support digestion absorption because of that low products of protein breakdown, low pancreatic elastase. I put some liver support in there, NAC 500 mg/BD, because she's on methotrexate. We know that that puts stress on the liver, but I'm also thinking of endotoxemia, LPS, more insult to the liver as we go through kill-off. And then I started off by working on some of the deficiencies with vitamin D, 10,000 IU a week for 3 weeks, then drop it to 5,000 IU a week for 3 weeks, then retest. Bisglycinate for the really low ferritin levels, methyl B complex to replace a folic acid. I can't tell you, ladies and gentlemen, how much I hate doctors, rheumatologists putting their patients on folic acid, but they can't take it 7 days a week because of they can't take it on methotrexate days because it reduces the efficacy of the methotrexate. So 6 days a week and throw the folic acid away. And then 500 milligrams of magnesium because that was in the red. So she came back to see me after 6 weeks. Her CRP had dropped to 12, her ESR 16, and her vitamin D was up to 76. Her ferritin was up to 28, and her white blood cells are just starting to drop to 7.2. She was on methotrexate, she'd stopped the folic acid, she'd stopped the ibuprofen, and she'd said, I'm not starting biologics, I want to give this a go. She found a significant reduction in inflammation, morning stiffness, and overall pain. She felt her energy levels had improved significantly. Well, I'm not surprised, by just getting her vitamin D and her iron up. So what did I do then? Supported her gut integrity with DGL, marshmallow, mastic gum, 3000 IU of vitamin D, which we know vitamin D is important for brush border enzymes, as well as vitamin A as retinol. I also put some NAG in there again for gut integrity, but NAG also does some nice work on synovial fluid from a joint integrity point of view. I then went on to bring in some mushrooms. I love mycotherapy, used lion's mane to support gut immunity, carried on with the methyl Bs, carried on with the magnesium, and switched out NAC to liposomal glutathione. So review after 4 weeks. She'd had acute worsening of gut symptoms. She called me up. She'd had acute worsening of gut symptoms. She'd had a takeaway, which she thinks had gluten in it. So she said, I don't want to waste time, Joe. I don't want to go backwards. Please just order me another GI-FX. She'd gone up to 4 to 5 bowel movements, loose daily. She'd got winds, she'd got bloating. So we repeated the stool test, and yet she was absolutely right. That dysbiosis score went up. And you can see here, her inflammation-associated dysbiosis had gone up. Her pancreatic elastase was still low, but her products of protein breakdown had risen. Her fecal secretory IgA was in the 4,000s, and now it was down to 803, and her butyrate was on the way up. And then from a dysbiosis point of view, she's still got that Dusoflavibrio-Piga in there, not a lot else. Her Akkermansia had actually gone up. And then from a bacterial point of view, she'd still got Faecalis in there, but she'd also got a little bit of Candida as well. So I went back in for the kill. I added berberine back in there, also put some caprylic acid with it and some allicin. I'm thinking, still got SIBO, let's make sure we're covering all bases of antimicrobial. Carried on with the methyl Bs, carried on with the magnesium, carried on with the glutathione. Came back to see me after 4 weeks. Her gut symptoms were now returned to normal with 1 to 2 bowel movements, no wind, no bloating. Her most recent blood CRP was 5, ESR was 12. Both of those, it should be 5 or below and 12 or below. So they're sitting on the top end of normal. Vitamin D was 98 and her ferritin was 48. So I put her on some mucin supports. I also put her on some proanthocyanidins to help to nourish the different species of bacteria within her gut. I added in some alpha-lipoic acid. If you go back to her metabolomics, her ALA was really low. So I'm now thinking about trying to stop binding toxins, aid in elimination. Remember, chemicals can induce molecular mimicry. Carried on with the methyl B, carried on with the magnesium, carried on with the glutathione, and dropped it down to just 1,000 IU of vitamin D for maintenance. She came back to see me after 6 weeks. She'd just seen a rheumatologist who said no active joints. There was no active arthritis for the first time since COVID. Her energy was significantly improved. Her next goal was to come off methotrexate. So we went on to spore-forming bacteria, try and push out any residual SIBO that was in there. Saccharomyces boulardii, because don't forget she'd got a bit of Candida in there this time, and partially hydrolyzed guar gum to again work on diversifying that microbiome. Carried on with the alpha-lipoic acid, B-complex, magnesium, glutathione, and vitamin D. Now, this takes us up to 8 weeks ago. current situation. She is now talking to a rheumatologist about the potential of a trial of methotrexate. She's not there yet, but she's talking to a rheumatologist about a trial. How phenomenal is a journey like that on making such a huge difference? She was just about to embark on biologics. You don't generally go on biologics for anything under 2 years. I'm not saying that she is free of autoimmunity. She has had a massive autoimmune hit. But why I wanted to put that case study in front of you was using the data to take her on a journey. Her tests weren't actually horrendous. She wasn't so far out of balance that it wasn't repairable, but it just goes to show how much, without digging down deep, you're never going to make a difference to the symptoms. But yet the tools in our kit bag are, I'm not saying superior to that of her rheumatologist, they're different to that of her rheumatologist. And actually, we need to access both sets of tools in situations like this. Their tools are largely not ever going to be enough. Put the two sets of tools together and you can make a difference. So thank you so much for your time this afternoon, and I will take any questions.
Thank you, Jo. That was an excellent presentation. Lots of information there at the very beginning that I think I'm going to have to keep going backwards and forwards with, and taking notes and stopping. You know, it's one of those, you know, that kind of information, the sort of underlying factors there of autoimmunity are so important to understand. But the immune system is so complex, so it's difficult to memorize all of those different pathways, and but yeah, very important to know as well, for sure. So I have a few questions here. Lilia is asking, you mentioned that you recommended 3 grams of fish oil. What levels of EPA and DHA would you be looking for in that?
So that was Eskimo Extra, which has a higher EPA. Remember, DHA is great for like neuro brain inflammation, but it's EPA that has the higher propensity to work on the PPAR receptors and downregulate inflammation. So it was a higher EPA to DHA, but if you're pushing me on milligrams, I can't actually remember, but it was Eskimo Extra.
Okay, fine, thank you. And then I've got a question here from Maha. Which magnesium is best for rheumatoid arthritis? Would you say malate?
Yes, I went for malate because not only had she got the joint pain, she was also getting other connective tissue pain, and malate works much nicer at sort of getting into the muscles.
And how much would you normally recommend of that in a typical circumstance like this one?
I mean, for her, I used 500 milligrams. I think largely people massively underdose magnesium. Like if you think most capsules contain 100 milligrams, and you know, generally people might go, I'll take 2 a day, 200 milligrams. I mean, even a good diet, you're likely to not hit more than what, 80 milligrams a day through diet. Put an Epsom salt bath in there and you might get up, I don't know, you might be lucky to get 150 milligrams. When you see magnesium in the red on a Nutritional or a Metabolomix, you really need to be thinking of doses in excess of 400 milligrams. Somewhere between sort of 400 and 600 milligrams is generally where I go therapeutically. And that does mean 5 pills a day was the 500 milligrams. And people, I think psychologically, people are like, I've got to take 5 of those a day. And this is where our education about what you can get from your diet, where you can get that magnesium-rich foods. And yes, I do often say, you know, transdermal will boost it. I'm like big into what else you can do. But honestly, I feel that magnesium is underused in the field.
I think also those products are often quite expensive, especially if you're getting a good formulation like magnesium bisglycinate or 3 and 8. And so to get to that dose, it's, you know, a significant investment when you're thinking of the other supplements someone else needs as well.
I get that. I absolutely get that. But then you've also got to say how much of our life can be given away to a disease complex like this, and it's kind of speculation to accumulate, isn't it?
Yeah, absolutely. Yeah. Okay, let me just see if there is another one here. So Jurgita is asking, would you do a thyroid plus test as well in this case?
If I wasn't making the progress with, so I don't disagree, thyroid could be a factor. Like there's there's a significant autoimmune history on the paternal side. I can't rule out that there might not be Hashimoto's. I guess what you've got to say is, what would I have done different? Yes, if she was showing like her energy hadn't have come back, I would have absolutely thought that. But what would you do in Hashimoto's? Again, you would optimize vitamin D. Again, you would go gluten-free, get out the reactive foods. Again, you would work on the leaky gut. Again, you would work on the bacterial dysbiosis. So I just felt that she was making the progress. It didn't scream I was missing an autoimmune disease at me. Had she not made the progress, absolutely, I'd have gone back in for the dive.
Yeah, sure.
Hormones were on my mind, like, do I need to test her sex hormones? But you've got to start somewhere, and that's why I always do such a good review of the systems, to be like, where is my go-to it? And I felt that the GIFX and Metabolomix were my absolute gotta go there.
Yeah. There's another question here as well about celiac. So is that something that you might have tested, particularly with the reaction she had, at least, you know, during that time that you, from the first consultation to the second one?
Yeah, but then wouldn't you have seen somebody react to gluten in that way? Do you want to put them back on a 6-week challenge? No way. Like, could you imagine the pro-inflammation? Because that's what they want, is they want a 6-week challenge. What you could do is test for HLA DQ2 and DQ8. If they were positive, you're like, it's likely celiac. But I mean, honest to God, the compliance of this girl was phenomenal. Now, I do always have that conversation with them and go, if we're missing celiac, then potentially we've got to think about cross-reactivity, because there is a difference between a gluten-free diet and a celiac diet. I've got a celiac daughter. Our house is completely gluten-free. Nobody's allowed to put bread in our toaster that isn't gluten-free. But to be fair, she was living on her own, so there was only gluten-free products in the house. And after that episode of when she had a takeaway, and although she'd asked for it gluten-free, she swears there was gluten in it, she was being really mindful about it. So she was behaving in that way. Now, I guess if she'd have been like, right, okay, I'm feeling better now, let's reintroduce gluten, that would definitely have been a time I'd be like, yes, okay, now we need to think about, is this a celiac? But she was behaving as if she was a celiac. So therefore, I certainly wouldn't put somebody back through a gluten challenge to prove what she was already doing.
Yeah, of course. And I guess it wouldn't just be a one-off, you know, gluten intake on one day. Would have to be over a period of 2
years. You to do the celiac challenge, they suggest that you eat gluten every day for 6 weeks, and what they're asking for is the size of a slice of bread or a handful of pasta equivalent. Like, that's what they want. And I know this firsthand because I was being told to put my daughter through it to prove right. That was a lot. That's a lot of gluten. Now, one could argue, come off it, a smaller amount of exposure would strip the villi. However, what you don't want somebody to do is go through an endoscopy, having not prepped properly, and then get a false negative, and then be walking away going, well, I'm not celiac, so I don't need to behave like a celiac. So you kind of got to weigh up that. I really don't like reintroducing gluten for a celiac test. I would just go, if you're HLA-DQ2, you're HLA-DQ8 positive, you need data to prove to you. In my opinion, that's enough data.
Yeah, okay, great, thank you. Okay, I've got a question here from Mariana, who's asking about your view on the use of probiotics when a client is on methotrexate and Humira.
Okay, so I use probiotics when somebody's on methotrexate and Humira, so we do have to be a little bit careful over immune regulation So if somebody is neutropenic, but you don't generally see neutropenia in methotrexate and Humira, you might see it if somebody's on cyclophosphamide for autoimmunity, and you certainly would see it when they're on chemotherapy. So I don't use probiotics in chemotherapy, but I do use it in methotrexate, Humira, infliximab, all of those kind of drugs. But we're seeing the bloods on a regular basis, and this woman was far from neutropenic.
Okay, thank you. Okay, did you hold off on the probiotics until you were confident you had reduced the SIBO and Candida?
Yeah, absolutely. So you can use spore-forming bacteria to kind of press out, and had we not had this extra hit to the gut, then I might have used them earlier. But of course, she called me and said, please, can I do another stool test? Like, that's how bought in she was by the concept. So she was like, I want to do another one. I want to find out what's made me go backwards, because there was such I'm moving forwards. Whoa, I've just been hit back. So then that's why I went back into kill off. Now, truthfully, had she not been so bought in by the benefits of it, we could have just done another round of kill off and seen how we were getting on. But once you've got that data and you start putting that data in front of people, they use that data to drive their journeys forward. Another one of those kind of anchor points that so many of my clients, particularly my post-cancer clients, love to use is A2-HTG and lipid peroxides. And I only fed one back to an 18-year-old yesterday that is now coming up 2 years post-leukemia. And mum was in tears when she saw that his lipid peroxides had dropped from 12.6 to 6.8. Like, mum was physically in tears. And they have such power, and how beneficial is that to be able to see these anchor points improve? And things like oxidation is dangerous. There is no other word for it. It's dangerous. So you leave somebody with oxidative stress in the body, and you are setting them up for a chronic disease, whether that be cancer, cardiovascular disease, or neurodegenerative diseases. So using those two markers and then watching them improve is so powerful. And that's what she wanted the test for.
Yeah, no, absolutely. I agree. Having that data to, as you said, anchor you is really important. We get a lot of practitioners asking about whether there is a risk of supplementing high doses of omega-3 when there are high lipid peroxides, and whether that can actually stimulate a high level of oxidation. Would you say, well, what would you say about that?
So I always say you've got to offset. You've always got to offset, and the offset is antioxidants. So for her, in plan 1, I just started to focus on diet, like eat a rainbow, get some green tea going in there, use some cacao, which is an amazing proanthocyanidin in food. And then on, I can't remember what plan it was, 3 or 4, it was actually Biome Essential. I just copied the ingredients list, but it was Biome Essential, which is a really powerful antioxidant. Obviously, it's sold as improving diversity to the microbiome, but the ingredients are all really powerful antioxidants. So I'm therefore offsetting constantly that balancing point. So the answer in short is yes, it can. The answer in long is it can, but you can do something about it.
So just making sure that they've got all of those plant antioxidants in at the same time. Yeah,
absolutely.
Yeah. Okay, so Nicola is saying here she'd like some guidance on helping a client talk to their rheumatologist about coming off of methotrexate. Do you ever have a pushback on this? It's hard to know if the terrain is better, but would the rheumatologist instead suggest it is the methotrexate which is making the joint improvements?
Of course, the rheumatologist is going to say that their tool is what is making a difference. Of course they are. What you've got to remember is, in an adult, it's a little bit different in pediatric care, but in adult care, the patient has the right to make decisions. And yes, you want the support of the doctor, but the patient, at the end of the day, you don't inject you don't inject, you're not on methotrexate anymore. You know, that's a choice a patient can make. And we as practitioners can't advise that. We as practitioners can say, have the conversation with the rheumatologist. Now, that rheumatologist was of the belief that it was his drugs that had made a difference. But what you've got to say is, she was on metho and steroids and non-steroidals when I picked her up, and she'd got flares all over the place, and her blood markers were all over the place. So it wasn't working then, was it? And then by the time I'd got, you know, finished with her, we were off steroids, we were off non-steroidals, there was no inflammation, and there was no active joint. So it's a bit of a duh scenario. Of course it wasn't going to be what they did. But I think what I always say to people is, you've got to go in there and you've got to dialect with your rheumatologist. Now, generally, rheumatologists want you disease-free for 2 years before they start taking you off drugs. But it's one of those, if you don't try, you don't know. Now, most rheumatologists don't wean people off metho, they just pull it out, which is, there's no data to say if you wean somebody off metho, you've got less of a rebound flare. But if it doesn't work, you put metho back in, you know, yes, it might take a bit to settle it. So I always say to people, so when you go to rheumatology clinics, you have to fill in a questionnaire, quality of living questionnaire, which joints are affected, what jobs can you do, can you open a packet of crisps, can you jar, you know, screw a jar, etc., etc. And they tot it up and they give you a score. Now, they will have seen her scores drop and drop and drop, and therefore he can see that she's within the normal blood parameters, no active joints, her scores have dropped. I don't think you're going to get much argument with giving it a go.
Yeah, they can't really ignore those signs. Yeah. Okay, couple more questions if you don't mind. Would a GP normally test for the haplotype, the HLA?
No, unfortunately not. So you can occasionally. My daughter, at the age of 8, was the first child to be diagnosed in the Midlands. I don't know about UK, but in the Midlands by HLA DQ2 and DQ8 halotyping, and that's because she could not go back on gluten, and they screwed up her date for her endoscopy. So because of that, they took her blood, sent it over to Spain. She came out HLA DQ2, DQ8 positive. I'd already done the Genova celiac panel on her. She was high positive across the board on gluten. So I put that in front of them. They ran the HLA DQ2, DQ8. They diagnosed a celiac, and she never had an endoscopy. But that was paid for by the consultant, and it was kind of paid for on compassionate ground, not from the GP, because everybody's budget is different. So you may get a gastroenterologist to do it, but I mean, trying to get a patient in front of a gastroenterologist nowadays is near on impossible.
Yeah, the waiting time.
So, well, they're not even accepting, even if the GP refers on, then the you know, secretary, you know, the person with all the medical advice, reads the referral and goes, no, that's not worthy. So if they haven't got, they're not on the 2-week cancer pathway, and they don't have other evidence like raised calprotectin, getting in front of an NHS gastroenterologist today is near on impossible. This patient would not have been seen by a gastro. So unfortunately, no, but you can do it through the doctor's laboratory. You can pay out of pocket, you can get that data.
Yeah, great, thank you. So just one more question here by Natasha. She is asking if you can remind her of the name of the professor you mentioned who specialises in EBV autoimmunity. Professor
Bump, B-U-M-P, like Mr. Bump. He's such a clever guy. He spoke at one of the IFM conferences. It was a pre-COVID conference. He got a standing ovation. It was phenomenal. Just amazing, his work on EV. Now, it is more geared towards MS, but obviously what he's saying is you can apply that data to other autoimmune diseases. It's looking at viral load. We know that EBV never goes away. We know that you create memory cells to it. So constantly need to work on lowering that viral load, whether that's with like monolaurin, cat's claw, olive leaf extract, to dial down the amount of viral load is what you've got to do.
Okay, fantastic, thank you. Great, that's our questions. So again, thank you so much, Joe, for your time. We really appreciate it. As always, really interesting content. Just so everyone knows that this webinar has been recorded, so I will be sending the recording later on today to all of you, as well as the slides, which, as you know, are in the handouts anyway. But if anyone has any questions that they felt haven't been answered and they want to ask privately, then please do relay that to perhaps us, and we can then forward it on to you, Joe. Our email address is clineduk@gdx.net. I can put that in the chat box now. But I think we'll leave it there for today. Again, thank you, Joe. I hope you have a lovely day, and hopefully see you at some point very soon.
Thanks, everybody.
Bye.